today my panelists are Dr. Suresh from Chennai. Dr. Gunjesh, unfortunately, is not able to join us from Ranchi. He is in unwell. Dr. Saurabh from Thrissur. Dr. Mukesh from Gurugram. Dr. Krishna Chaitanya from Hyderabad. Dr. Anuj from Varanasi. Dr. Shrikant from Hyderabad. And Dr. Manshi from Ahmedabad. And Dr. Pinaki Mahato. So they will be the medical oncologists on board with me today. And then we have our two elite surgical oncologists, Dr. Priyanka and my good friend, Dr. Veda. So with this, I will move on straight. So as far as the HER2 targets are concerned, this is quite well known that starting from, the early targets in 1998 when it was only trastuzumab, we moved a long way through. And what we have in hand now for the clinical practice, especially amongst patients who are HER2 positive beyond trastuzumab and pertuzumab. So that is TDM1, and today I've been asked to do a case panel on the same. So this quickly jumping to the case, a 40-year-old lady, premenopausal. She comes with a clinically T2 tumor and no node involvement on PET scan. And so I will start off with the surgeons on board. Dr. Veda, she's apparently a young lady, a small tumor. Would you just do an FNAC and go ahead with surgery, or would you like to have a true cut biopsy in most of these patients?
So as of now, we do true cut biopsies for all women with any breast lump. So the triple assessment is FNAC we do from the lymph nodes, but not from the primary. So as of now, the standard is a true cut biopsy from the lump and preferably ultrasound guided if possible. In
Thank
fact,
you,
the
Veda.
advantage is when we do it with ultrasound, we sample the primary as well as the axilla at the same time.
Okay, so you are going to go ahead with the biopsy. So how do you think this is going to change? Let me say if it was a 2 centimeter mass, you will still stick to the same, or would you prefer to finish off a surgery and then refer
So
them to the
if
medical
we
oncologist?
plan an upfront surgery, we would want to have a biopsy upfront because see, if it's a 2 centimeter lump, an FNAC is unlikely to differentiate between an invasive and in situ component. So if it's a DCIS or invasive ductal carcinoma, again, that is going to have an impact on the axillary staging. So we always have a core cut or a true cut biopsy, irrespective of the size of the lump.
Thank you. So what about Dr. Priyanka? Would you
I
agree
would
with
agree
your
to
colleague?
that we would do a biopsy irrespective of the size.
So I think this patient did go through the same. There was a biopsy which was done pre-operative, and it turned out as a infiltrative ductal carcinoma, a triple positive, a ERPR positive, and a HER2 3+. So I will start. So in once you have this, I'll still stick to the surgeons. Dr. Priyanka, I'll start with you. Is this patient in your center going to undergo a surgery, or would you refer this patient for neoadjuvant chemo?
So I would refer them to a medical oncologist to discuss the affordability and feasibility for an HER2
Veda?
neo.
So yeah, see, all patients we have a MDT team, so we discuss accordingly. And again, this particular patients, see, rather than, of course, ideally it is now we have HER2 positive T2N1 disease going ahead with NACT. But in the real world scenario, again, in a node negative disease, the only concerns for me is the accuracy of sentinel lymph node after chemotherapy comes down, and of course the cost issues. So again, patient to patient, we tailor, we sit around with the patient to discuss
Now,
what
here you have a patient, T2,
yeah, she is node negative.
HER2 positive, node negative,
Node
T2N0,
negative. So
node negative.
yeah.
So here, if it's a T2N0 node negative, HER2 positive, will they go for neoadjuvant or will you go for
See,
straight
ideally,
surgery?
yeah, all node positives or even more than 2 centimeter node negative, NACT is the standard of care. But in the real world scenario, the challenge we face is, of course, the cost. So again, we would stratify in a node negative patient and ERPR positive patient. See, ERPR negative and node positive, the advantage of targeted therapy is much more. So in a node negative scenario or in a triple positive scenario, in a very early disease, we still discuss with the patient regarding upfront surgery also.
Okay, so this patient actually has the choice of both, but if we go by the guideline, especially in the two high risk groups, especially if they are either triple negative or if they are HER2 positive, any patient with T2 disease or more, they ideally can go for neoadjuvant chemotherapy, because we have been, as our earlier panelists alluded, there has been some data for producing the maximal complete response, and which has later we have some data on mental analysis and other studies which show certain amount of survival gain on these patients. So let us say that this patient was okay to go for a neoadjuvant chemotherapy. I will start with Dr. Suresh. So, in your center, because we have a variety of panelists today with us across the country. So, Dr. Suresh, quickly the call which you follow in your center.
Finally, since the patient is HER2 positive and 3 centimeter, I will go for AC followed by trastuzumab and taxane. Pertuzumab if feasible, but mostly I'll go for the AC followed by trastuzumab and taxane.
Do you do an interim assessment, Suresh, or do you take the patient for a total neoadjuvant and then subject them to surgery at the end?
So I'll assess the patient clinically whether the mass size is decreasing or not. If clinical response is there, I'll wish to complete the chemotherapy before surgery.
Dr.
Can I
Krishna?
interfere in between?
Yeah, please.
Dr. Priyanka.
Yes,
I just wanted to know, do we do an axillary tissue diagnosis before chemotherapy, or are we happy as surgeons to do a post-chemo sentinel node?
I think Veda, you should answer that question, because
so
here is a node negative patient clinically and PET-CT node negative.
Practical challenges in this scenario is only two things. In node negative, again, the accuracy of sentinel lymph node drops down after neoadjuvant chemotherapy. But
no, can we do a pre-chemo? Can we do a pre-chemo ultrasound guided core?
So ultrasound guided FNAC, we do it upfront. So that's what I said. When we do a biopsy, we do it ultrasound guidance. So we do the biopsy from the primary and we do an FNAC sampling from the lymph node. So we are sure of the nodal status upfront. Okay. And the second thing that we need to do is, especially when it is a small tumor where we're expecting a PCR,
clip.
This thing we put in a marker.
Clip insertion.
Yeah.
Absolutely. Thank you.
So Dr. Krishna, thank you, Priyanka, for that. Dr. Krishna?
Yes, sir. Sir, Roti, because she is a premenopausal lady without any contraindications for anthracyclines, I would prefer dose-dense AC followed by taxane with herceptin. And TCHP is also one of the option, but routinely we are not using. We would prefer dose-dense AC and taxane and herceptin.
So, what Dr. Srikanth, you also practice the same, what Dr. Krishna has mentioned?
No, sir. Actually, I am from Andhra Pradesh and I am from Guntur. And for every patient, I would like to recommend TCH and chemotherapy with single agent with trastuzumab. And those who are affordable, definitely I would like to go with TCHP, sir.
Okay. So, how about Dr. Mukesh?
I would like to go with TCH, and if affordability is there, then pertuzumab can be used. At our center, we generally use this combo.
Yeah. So, and how about Dr. Anuj and Dr. Manshi? From
Yes,
your
sir.
part of the country, what are
Yes,
your
sir.
preferences?
Yes, sir. Since it is a node negative disease, we can avoid anthracycline, and we follow TCS for such patient in the adjuvant setting, in the neoadjuvant setting. And if the patient is affordable, we can also add pertuzumab for such patients.
Okay, Dr. Manshi.
So, sir, I agree. Non-anthracycline based regimen, I think, is good enough for this patient. So, TCH plus minus Perjeta, depending on affordability.
Okay, so I think there is no one single answer, as people have mentioned already, based on the practice preference and the presence of insurance and how deep the pockets are. We will be able to take the choice depending on that. So I'll quickly go back to Dr. Suresh.
Yeah, I just want to make a point that if the patient has a ERPR negative and the HER2 is positive, in that case, I think it makes a case for adding Perjeta, because you see that the difference in the PCR rates are maximum when you have a ERPR negative and HER2 positive scenario. On the other end, if you have a triple positive or a ER positive, HER2 positive, in that case, probably we can tempo down the role of Perjeta. I mean, we can tell the patient that is the additional molecule, but the PCR rates are not really very, very different. But if the patient is ERPR negative, HER2 positive, in my setting, I generally ask them to go for the pertuzumab, because there is a difference of almost I think 30-40% in the PCR rates if you add pertuzumab in that setting.
Yeah, that taken. Of course, we'll be coming on to that slide where you can just quickly see the difference between the ER negative and the ER positive subset. So since Dr. Pinaki, you have taken up the topic on PCR, what do you define as PCR in your center? Do you look only at the tumor or you look at the nodes also?
So ideally, I think breast PCR, axillary node PCR, and absence of in situ. These are the three ways in which we can define PCR. So at my institute, generally, presence of in situ disease is also included in the PCR, but the German group actually they do not include. So you should ideally have absence of in situ disease as well in the breast and the axilla.
Okay. Now let us assume that you have added one single agent, not dual blockade. In your experience, Dr. Mahato, what is your percentage of PCR?
Around
Let us say 100 patients you treat with the
around 30 to 35% patients of mine, sir, achieve a PCR with single anti-HER2. Yeah.
Okay, that's a very good figure that you have put forward. Excellent. How about Dr. Suresh?
2 seconds, that sir, roughly around 35% of the patients achieve PAT-CR.
Okay. Is there any objective like how you go to your pathologist? Now, if you see based on the ERPR, of course, Dr. Pinaki wanted to make it either single or a dual HER2 blockade. Is there any score which you are using in clinical practice in any of the centers for the post-operative residual cancer burden? Dr. Gunjesh or Dr. Mukesh, because this would lead on to decide on the adjuvant therapy. So there was actually an RCB score. So some patients who have achieved PCR, well and good, we know that they have definitely the disease-free survival is better and the events post chemotherapy and surgery is better. And if they have an RCB 1, 2 or 3, then based on which the event-free survival starts climbing down. So there are certain centers which are giving us the burden of the residual disease that is left behind. So here, this is what Dr. Pinake was actually mentioning. So these patients were ER negative and HER2 positive. Obviously, they are the ones who benefit maximum response from dual blockade, and especially if you are going to at least give a single agent blockade, you can see that if you give docetaxel with trastuzumab, it's about 36.8, whereas if you give a pertuzumab with trastuzumab with docetaxel, it is 63.2. So nearly about twice the PCR you are able to achieve. So this was the data from the Neosphere. And then adding an anthracycline also, because this has always been a debate in HER2 positive patients. Can you really get rid of anthracycline? Because we know that the two diseases which are technically bad in our clinical practice, one is HER2 positive, the other is triple negative. So we do have the experienced and the senior and the old timers or the whatever we can call them, who would always like to still keep anthracycline somewhere there because they know that the subset is going to do badly overall. So if you add an anthracycline, still you can see the CR rates are actually slightly pushed up from the range of about 40s to about 50s, 55, 55 and 56%, which was there from the phase 2 trifina trial. I have not gone into the
yes. Just so we saw the train to that anthracyclines do not benefit much, but I think if you have seen the subset analysis in the train 2, the patients who did better with anthracyclines were those who were ERPR negative and HER2 positive. I personally thought that patients who are young probably would do better, but it seems that even in the train 2, patients who are young actually did worse on the anthracycline arm. So the only patients who benefited with the addition of anthracyclines were those who had ERPR negative and HER2 positive. Otherwise, other patients did not benefit by the addition of.
If you actually see in that way, the hormone positivity itself overall brings the graphs down in all subsets, and that is quite well known. And as you mentioned, and as you were on the dot, the ERPR negative subset with the aggressive biology, they are definitely going to benefit by addition of anthracycline also. That is why the TCH is still a favorite arm for many of the patients and many of the physicians, because you somehow down the line you feel that giving these patients adjuvant for another 1 more year, it is safer to keep the anthracyclines away. So well taken, and especially if it is an older patient, you are definitely going to go for a TCH and get rid of the anthracycline. So this was, of course, this is one graph from a meta-analysis which went on to say that the EFS and the OS is really different from patients who have residual disease. So coming back to this patient, as per some of the choice of our panelists, this patient received TCH into 4. They could not afford the second HER2 blockade. And then the lump was responding well. The patient completed total neoadjuvant with 6 cycles of TCH and then underwent a BCS. And then there is a residual disease of 1 centimeter and the node is, however, negative. So here there is an residual disease post neoadjuvant chemotherapy with 1 HER2 blockade. So I will start with Dr. Krishna Chaitanya. Sir, what would be your choice of adjuvant at this stage?
So it's post neoadjuvant trastuzumab exposed and there is invasive disease present. So I would like to escalate the anti-HER2 therapy to TDM1 for 14 cycles.
Okay, Dr. Gunjesh, do you agree and go ahead with the same TDM1 for this patient? Okay, sir is not there today. Okay, sorry, Dr. Mukesh.
Yes, I will also go with the TDM1 and it complete for 14 cycles because we did not achieve the expected path CR in this case.
Dr. Pinaki, your take on this?
Definitely, I think with the existing data, we should go for TDM1 for 14 cycles.
So I think maybe if you are talking about a similar topic about 2 years ago, we would not have spent this too often. Let us say, because we are doing a panel discussion and we've got panelists from across India, from various cities and states. TDM1, especially the biosimilar, has been launched and it is available for the last 1 year, which has made life a little easier for us. But ahead of that, if you really ask us how many of us were able to apply the Catherine study, it was not, it was really a hand full of patients. But now I think we have more patients who are going on to TDM1 for patients who have residual disease post neoadjuvant chemotherapy with HER2 blockade. So this is just the Catherine study, which all of you, I'm not going to go too much into the detail. It's randomized between TDM1 and trastuzumab, and even the patients who had to be discontinued on TDM1, they continued only trastuzumab and completed the 1 year therapy, that is 14 cycles. And then the Catherine did show definitely 11% improvement in the invasive disease-free survival. And you can see across all the subsets, there is an improvement. And that is why all the panelists uniformly have opted and then they support that they would like to continue an alternative TDM1 because of the presence of residual disease. And if you really go back and see who are all benefited, here you can see almost everything. You can see the plots are to the left of the unity. And I would just like to bring it here based on the, the disease burden score, which I was talking about. The higher the disease burden and residual disease burden, the RCB score, better they do. And that goes to say that TDM1 in the adjuvant setting for 1 more extra year after exposure to HER2 would make a case in our patient. So here I just have another question to, let us say Dr. Shrikant can take this. Let us say the patient was affordable. Patient was able to take pertuzumab also in the neoadjuvant setting. Let us say the patient received TCHP. This patient was ERPR negative. Dr. Pinaki brought that excellent point. Yes. ERPR negative, HER2 positive, they are going to do bad. So it's a double weapon that is there against us. So let us say he got his patient to get TCHP. Yes. Does TDM1 still make a big difference when you're given a dual blockade? Do you have any data on that?
Irrespective of the previous therapy, like whether patient is received single HER2 or a dual HER2, and definitely there is a benefit with the TDM1, sir, irrespective of the whatever the previous regimen, and definitely there is a benefit.
So just as you straight went to the point. So this is the graph which is going to show that irrespective of what was the prior therapy, whether it was a dual HER2 blockade or a single HER2 blockade, the TDM1 just added on to the benefit. It built on the benefit which was already given by the neoadjuvant HER2 blockers. Dr. Manshi, I would like you to take this question. Suppose this person turns HER2 negative. This is not a very uncommon scenario. There is residual disease, but the HER2 by IHC, and if you are so intrigued about that, you do a FISH and still it is negative in the post-op specimen, will you still consider completing 1 year of adjuvant TDM?
So, sir, I think there is some data suggesting that about, I think, 10% of patients can turn HER2 negative in the post-op, in the operative specimen, if they've received anti-HER2 therapy. But I don't think there is any data to suggest that these patients benefit less from anti-HER2 therapy in the adjuvant setting. I think prognostically, these patients seem to do worse than patients who retain their HER2 positivity. And I think for this reason, we still don't check the HER2 status again in the surgery specimen.
Dr.
So,
Suresh, would
yeah.
you support Dr. Manshi on this? So we have had a HER2 positive upfront and we have given new adjuvant. So I'm not going to check the receptor status. This was probably just done ad hoc, but we would have otherwise just gone ahead with the original plan. Or are you going to just continue hormones?
Yes, sir, I would agree, sir. We would continue the original plan. In our institution, we don't routinely check the surgical sample also for the HER2. If the patient has received a HER2 in the neoadjuvant setting based on the HER2 status on the biopsy sample. So, and also the Catherine trial, some data is there. About 10% of the patients do turn HER2 negative, and they also show benefit with adjuvant TDM1.
Very true. So I think both our panelists have alluded on the same point, and this was also presented in the ESMO 2020. And then
Dr.
there is
Krishna, I would
data.
like to share a case.
Yes.
Actually, we
Yes.
had a patient who was ERPR negative or positive. We had given her TCHP 6 cycles. Patient did not have a PCR. She had 6 lymph nodes positive. So my take would be definitely we should, in a patient who is initially ERPR positive, does not get a PCR, you should repeat the ERPR at least on the histopath. And I did the HER2 as well. So I found that the ERPR was still negative, but the HER2 also became negative. But as you said, the data is that we should continue the adjuvant TDM. So why,
Exactly.
the
So
only
that's
thing is
what actually,
if patient was initially ERPR negative, we should not miss out the ER expression if the patient did
exactly.
not get a PCR.
Exactly. So, I mean, that is one reason where still, although we don't have exact data for what we are practicing today in the clinics, I think still we do run the receptor status even in the, we get a YPT report along with the ERPR. But of course, if we have somebody who is HER2 positive and then even if they turn HER2 negative, we go ahead and then here is the data which was actually put up in ESMO 2020, and then that supports that we need to continue, which the panelists have clearly told us. So, Dr. Anuj, your take on your personal experience with TDM1, let us say even ahead of the biosimilar, or even now once the biosimilar is in place, are you able to give them all the 14 cycles, or are you experiencing any peculiar toxicity with TDM1? Dr. Mukesh, you can take the question?
Yeah, in my TDM I use in metastatic cases, most of the cases, because I am not able to use because of cost issue in adjuvant neoadjuvant setting. So what I have seen that thrombocytopenia is a common side effect with the TDM1, and in few cases I require dose modification also. Apart from that, some transaminitis I have seen, and a few cases the neuropathy. So these three notable features I have noted in the patients who are on TDM1.
Dr. Krishna?
Sir, I have only 4 patients on adjuvant setting, and I just completed 4 to 5 cycles average.
So you've been very comfortable
No.
with the dosing,
Yes.
3.6. You're able to
Yes, sir,
stick to
that's good.
3.6
Yes, sir,
kilogram per kilogram. Dr. Pinaki, your take on
Fatigue
the dose?
is sometimes seen in few patients, and thrombocytopenia. These are the two sides. But transaminitis is asymptomatic. We generally do not.
Correct. And then usually what we have seen is after the first few cycles, it actually starts setting down. And if you put them on some liver protection and then take them forward, mostly by the second or third cycle, it picks up. And then even the neutropenia and other things, I don't know whether the body learns to adjust itself. We are able to nearly go on to the prescribed 3.6 milligram per kilogram. And even in the trial, you can see that almost 14 cycles, more than 2/3 of the subject, they were able to complete it as per schedule, and there was not much dose reduction except for 15% of patients, which our panelists have also shared in their personal experience. And as correctly mentioned, it is the hematological toxicity, especially a mild thrombocytopenia that may cause some dose delay and then probably about 10% dose reduction and mild transaminitis. And most of them, they are manageable and in single figures. So if you really look at the NCCN guidelines and as what our panelists have all brought us together, yes, the surgeons are right. So they will go for a biopsy upfront. And if they are going to look for either breast conservation or if they are going to go for a sentinel lymph node biopsy, they may additionally do an ultrasound guided FNAC of the nodes to know the nodal status before harping on whether they need to address the axilla fully or not. And once we have a HER2 positive disease in hand, then there is a choice to go for neoadjuvant chemotherapy with trastuzumab, with or without pertuzumab. If preferably pertuzumab could be added in patients who are high risk, as Dr. Pinaki had mentioned, and then those who have a residual disease post surgery may be offered 1 year additional trastuzumab emtansine. So this has been there right up there in the guideline in category 1. And already our speakers here in the panel have mentioned that it is they have started using it. So what about cost effectiveness? Is it really going to mean that we are moving ahead? There has been only one a paper which has addressed on this and which did mention to us that if you use trastuzumab with pertuzumab, of course there could be a more chance of getting good PCR, but then when you use an adjuvant TDM1, it is still cost effective. But in India, we were not able to practice this until recently when we were able to develop our own biosimilar. And this TDM1 has passed through its various stages, starting from the structure, the function of the molecules, the PK/PD studies, and then there was the phase 3 randomized trial in the metastatic setting where they were able to prove that the biosimilar that India has evolved is non-inferior to the reference product. So with this, we've been able to launch the TDM1, and I'm happy to see that all our panelists have had their hand on this and are able to comfortably use this drug. So in this patient, the plan to give adjuvant TDM1 for 14 cycles was taken, and patient has completed about 2 to 3 cycles and is tolerating therapy reasonably well. So I think with this, I will close the panel, and I would like to take 5 minutes from my panelists if they have any questions.
I'm Naresh Somani. Can I ask a question here?
Yes, sir. Please, sir.
So neoadjuvant is given, and there is a not pathological CR, and you have planned for the TDM1, and the patient is ERPR positive. So
Yes.
when you would like to add the endocrine therapy after completing the TDM1, which is having the cytotoxic drug, or you would like to add the endocrine therapy along with the TDM1, as we do in the case of the trastuzumab adjuvant?
Very, very true. I think in my clinical practice, although there is a cytotoxic TDM1 which is there, as of now, I have been adding along with my TDM1. I would like to get the opinion from my other panelists, Dr. Chaitanya, Dr. Mukesh, and Naresh, sir. You can tell us because you're the senior amongst our lot here. Where would you like to bring in the
So
hormones?
I really don't know. I really don't know.
Because I am actually using it as we start. I have started using the hormones in my practice along with TDM1. Dr. Mukesh or Dr. Pinaki, where would you like to sandwich this? Because it does have the emtansine, which is a cytotoxin.
I do agree, but I would like to start with the TDM1 only because there is no point waiting for 1 year to start hormonal therapy. So I'd like to start with TDM1 only.
Dr. Manshi?
So, sir, I start hormone therapy just as you would start with the trastuzumab. So I give hormone therapy along with TDM1 in the adjuvant setting.
Okay.
And I think even the trial allowed patients to start hormone therapy just
because
as
it does mention that for 1 additional year of TDM1 with hormones in those who are ER positive. I think that's what is the wording, and we've just followed the same. So I think if there are no other questions, and since we've been running behind on time, the podium is back to Jyoti ma'am. And thank you to all my panelists, and thank you, Naresh sir.